Well, I think we're ready to get going. Thank you so much for coming. This is going to be a really great presentation and the start of a great day for Dr. Plough and Margaret from the Robert Wood Johnson Foundation here at the school. So I'm Josh Sharfstein. I'm the Associate Dean for Public Health Practice and Training, and it is my pleasure to introduce our two speakers this morning. Following this session, we are going to be having a Twitter chat at noon by the Wall of Wonder with the hashtag PubHealthChat, and we've gotten a lot of interest already in that, so we hope that you join. Let me introduce our speakers. Dr. Alonzo Plough is the Vice President of Research, Evaluation, Learning, and the Chief Science Officer at the Robert Wood Johnson Foundation. He came to the foundation about 2 years ago from Los Angeles, where he was the Director of Emergency Preparedness and Response for 4 years in the Los Angeles County Health Department. That's a big health department. That's a big city to be responsible for the emergency preparedness and response. Prior to that, he was the Vice President of Strategy, Planning, and Evaluation at the California Endowment for about 4 years. That is a big foundation. He also has served as the health officer for Seattle and King County Department of Public Health, and was a professor of health sciences at the University of Washington School of Public Health. He had his PhD and master's at Cornell and his MPH from Yale. I could go on and on, but I will say that he has an incredibly important job, which is, as the nation's largest health foundation is orienting itself to a new set of goals, his job is to figure out, in part, how to measure it, how to make sure that the foundation is achieving it, and the country is achieving it. So and that's what he's going to be talking about today. He will be joined by Margaret Tate, who works at the foundation and is also a student in the MPH program. Is that true? That is correct, at the school, and we are very glad that someone from the school is directly engaged in this important work at the foundation. So without going on any further, I will turn to Dr. Plough. Thank you.
Well, thank you, Josh, and good morning, everybody. Really good to be with you, and I look forward to wrapping up our shared talk with Margaret in time that we can have some question and answers, and I think we have the Twitter session afterwards. So what I'm going to really do in the time we have is take you through the journey that the Robert Wood Johnson Foundation has been through over the last couple of years, as we've really reoriented our entire foundation around this framework of building a culture of health. So I'm going to tell you a little bit about how we got there, the research and evidence base for how we got there, the deep engagement with communities and leaders around the country, where the rigorous listening to what people were thinking about that would improve our healthcare system and public health system was really important part of the framework that was developed. So you'll get a chance to kind of peek inside both the research development process and also see where we are around our culture of health action framework, how that has realigned all of our funding, and I'll end at the end with some new funding opportunities that we have. And Margaret Tate, who's been working hand in hand with me and the group from RWJF and our colleagues at RAND, will do the middle of the presentation on a view of the action framework. I think the things to really emphasize about where RWJF is now and something that attracted me when I came from Los Angeles a couple of years ago. In order to pursue this vision, it required internal change, an elimination of the division of the foundation between a healthcare and public health side of the shop. One foundation, in fact, what I learned, the first unifying strategic framework for the entire foundation around building a culture of health. So it's not an initiative. It actually reflects the 20-year commitment of the board to align everything that we're doing around this building a social movement, and I'll come back to that a number of times, to build a culture of health in America, which is really pivots, and I'll come back in almost a redundant way, to improving health equity, way beyond eliminating disparities, but achieving health equity. So we started the research and the development of the framework a couple of years ago, asking one essential question. What is holding our nation back? What is holding our nation back from the health equity that we desire? And that research question had two components. What do we really need to know more about, particularly if we want to eliminate health inequities? And what do we know a lot about that's quite evidence-based that we do not scale and spread? So that's the unifying question, particularly with Rand and other researchers that we involved in this, that led to the action model that we're gonna present. What's holding us back from communities where there is equal opportunity for children to attain, their best well-being, and all residents to have the highest quality health care. And so we conducted this research and developed this framework. But what I want to say about the framework, and I'm ahead of my slides here, so I'll back up. We developed this framework essentially to make sure that we weren't developing a rote kind of blueprint for a course of action, but an adaptive framework that could be used by us in our own strategic thinking and could be used by communities, other sectors who really want to improve health and well-being. And we involved many different people, and I like to talk about this as involving a lot of experts, rigorous research, but also a lot of rigorous listening to these different audiences. It really focused on a couple of really key themes. Achieving health equity, so everybody has equal chances to make choices to live the healthiest life possible. Improving access to high-quality, efficient health care, though we really have added to our work a broad social determinants of framing of our healthcare activities. We are still very interested in improving health and healthcare, particularly interested in driving those systems toward more integration of prevention and the social side of healthcare. I will be using, and we are using somewhat interchangeably, health and well-being, and we might want to come back to that on the outcomes. As I talk to particularly the kind of sectors that we want to get involved in improving health in America, the term health often makes people say, well, I'll say bankers or community development people say, well, I don't know about health. But if you talk to them about well-being, they do know how to work creatively to improve housing stock in urban cities. They understand how to do a number of things that improve the social determinants of health. So you'll see us talking about health and well-being and what kind of research and programs we need to improve this broader framework of well-being. So that's kind of the major kind of component of the background on the action framework. And again, I just want to emphasize that it is our entire strategic framework. The board has made a 20-year commitment, and all of our funding is aligned across the foundation to building this national movement. We like to call it an evidence-based national movement to build a culture of health. So this is an action framework, and I don't want you all to jump on our website right now, but you can find this laid out very well in our new website, cultureofhealth.org. And everything that I've got here will be there, so you don't have to take so copious notes. But don't go online now, because I want to make eye contact with you, and it'll help Margaret in my presentation. So again, along with the team at RAND, lots of additional research, and those of you who are interested in that research base, we can provide a document cleverly called Deliverable 1 that we did with RAND that will give you great detail on the methodology of how we got to this part. But again, I want to emphasize rigorous research and rigorous listening. So the framework is a set of guidance for national priorities that we think are really important for building a culture of health. And it really addresses what we think it needs to address the challenges that are impeding our health, the things that are holding us back. And it really requires us as public health officials, public health researchers, all of us involved in trying to improve health and well-being in this country, we really have to think and work differently. I know that sounds like an old Apple commercial, but it really do have to think and work differently. Different partners, different notions of what the outcomes mean, thinking differently that not just stopping with measuring disparities, but achieving health equity. This is a different kind of framework, and it draws on all of what we did, but it really needs to advance in a different way, in a much more collaborative way. And I think the notion of the outcome being improved well-being is one of the ways that we're trying to signal that. And at least you think that we are wistful about this. This framework represents talking to different groups all around the country, many who are also seeing these same things. Many places, many communities, and I'll talk about that at the end, that have this broad recognition that we need to improve health beyond improving the health and public health system, and there are many different examples of this. So this action framework really develops around, okay, if we want to have this broad social movement to improve health being in this well-being in this country, if we want to achieve health equity, if we want to address any cause of marginalization, be it race, ethnicity, immigration status, sexual orientation that leads to poor health and well-being outcomes, what is a way for us to get that? A way to frame that, a way to ask the question, what actions should we work toward? How should our actions connect with one another across sectors? And then on the metric side, we know what gets measured gets done, what specific measures will gauge improvement. So you can see here on the action framework, these 4 diamond areas are the areas that we've grounded our research. They're interconnected, and they are the areas that we think that if we work as a nation, not just the Robert Wood Johnson Foundation grant making, but if we work as a nation on these issues, that we can see the kind of changes that we want to see in terms of overall well-being and health equity over a course of the next 10 or 20 years. So again, making health a shared value. This came out of our CEO, Rizos Murray's 10 principles for a culture of health. Really that we as a nation need to believe we are in this together, that our health is interdependent. So Margaret will talk a little bit more about how we're thinking about those measures in just a minute. If there's an area that really differentiates our framework from, say, Healthy People 2020 and a lot of other really important ways that we try to monitor success, this is action area 2, fostering cross-sector collaboration to improve well-being. Again, the flip side of the social determinants of health, if we believe 70, 75, pick a number of percent of what drives health and well-being is outside the health and public health sector, then that says the assets, resources, the leaders in those other sectors really need to be on board with this. We need their assets in the mix. We need them if we're going to, we can't plow ahead by ourselves. We know that because we spend $3 trillion now pretty much by ourselves, and we don't have the kind of outcomes that we want to have. So again, cross-sector collaboration, figuring out inviting ways, actually inviting metrics, as Margaret will point out, that bring those other sectors into the mix to solve these structural problems that we need will be by developing and measuring very effective cross-sector collaborations. Action area 3, creating healthier and more equitable communities. Work I know that you've been involved in here. We want to have communities where essentially the healthy choice is the easy choice. We do not want to have communities where a couple of subway stops away, as we find in many cities, you have 3 or 4 or 5 years difference in life expectancy. So and again, health often does come down, in fact, always comes down to the decisions you make about being healthy every single day. But we have to have the opportunity, the environmental context, the social and economic conditions in order to make those choices. And that's what the healthier, equitable communities is about. And then again, we continue at the foundation to be very much interested and focused on health and healthcare and public health systems, but our emphasis is really on the strengthening the integration of health services and systems that range from interoperable information systems to another generation of collaborations between, say, public health, FQHCs, community organizations, and hospitals, really ramping up that ability. That's the framework, and we believe that if we get improvements in those areas over the course of time, we say about 20 years, we hope sooner, our long-term outcomes will be to improve population health and well-being, and you can see that equity is the overarching framework. Now, I've presented this a lot over the last couple of years. They told me at the end of the year that I've given 45 presentations on this over the course of the years, each one informed by the feedback that I've gotten from the audiences. But it's really intended, and these should not, particularly for a School of Public Health, look like entirely novel ideas. These are many of the things we've been working on for years. But I think putting them together, putting an evidence base behind them, developing a set of national measures, really trying to see this framework and drive the equity principles behind it is something that we at the Foundation hope and already beginning to see that it's a catalyst for the kind of collaboration that we want. Again, it is equity is the overarching theme, and it's just very important that we focus on that in our long-term goals. You'll see, and Margaret will present this a little bit more detail, the action framework, and each of them has a number of drivers. The evidence base led us to not just these 4 areas, but a number of different drivers within those areas that if we really move those, and you see a couple of them called out here, those are the engines of the framework. The measures that we'll talk about, we'll update many of those in the 2.0 version of that in early 2017. But these drivers and the framework we think is pretty solid as a framework for the work we want to do over the long run, long-term priorities that we hope will catalyze actions. Now, we have the 41 measures, and again, when you go to the website, you will see those 41 measures. You'll see even more than that on cultureofhealth.org. I have never given a 41 measure talk. No one wants to hear a 41 measure talk, but you can go to the website and see those. As you look at that and you see when Margaret presents some of these things, they're limited by the availability of national data, though we have done some new surveys with RAND in order to bring some new data in that's nationally relevant from surveys. Applicability to the entire lifespan and health span. A culture of health is not just for individuals who don't have a chronic illness or live with a disability. It's really about achieving the optimum well-being at any stage of the health span and lifespan. Again, emphasizing broad upstream social determinants and the appeal to multiple audiences. Again, why doesn't this look like Healthy People 2020? Why aren't these conventional morbidity mortality statistics? It's because the measures are designed to engage those other sectors who aren't usually part of the collaboration so they can see themselves in it. So that will help you to differentiate why we have measures like residential segregation or measures like the proper prevalence of community policing in our framework, because they lead to both engagement of the sectors that need to be involved and the kind of actions those sectors might need to take. I think with that, I'm going to turn it over to my colleague Margaret to take us through the framework.
Thank you for that. So as Alonzo said, and he primed us very well about the action framework and the work thus far to get us to this point, I'm going to dive a little bit deeper into each of the action areas, the drivers therein, and 2 measure examples. But as he also mentioned, we have all of this information and more on cultureofhealth.org, and would encourage you all to visit that site after today's presentation. The first action area, as he mentioned, is making health a shared value, which is very exciting and very much differentiates this framework from others, and focuses on the work that we need to take to put our nation's values and expectations about health front and center. It really emphasizes this importance of achieving, maintaining, and reclaiming health as a shared value, and is something that's top of mind in our professional, our personal, and our political decision making. And we recognize, or we feel as though when we do this, we'll fuel greater mindset and expectations about health, we'll fuel a sense of community, an increased demand for healthy places and practices, and a signal that individual actions have a role in the collective well-being of communities. So as you see the drivers on here, which again are the engine of the framework and around which we organize different measures are of mindset and expectations, of sense of community, and also of civic engagement. So very much just as what I was saying. A measure within this, and falling within the civic engagement driver, is of voter participation. And this is going to be a measure of state and national voter turnout, as reported by the U.S. Atlas on General Election. I don't think it's a stretch for people in this room to understand why civic engagement is an important driver and why we want to learn more about volunteering and voting, because this really signals that somebody is investing in their community and they see that their individual decision-making has a role to play with the collective well-being. We've also included a measure in here on the value of well-being, and Alonzo mentioned that we have a new survey that we're fielding among the RAND American Life panel. This is a measure that's going to be fed as part of that. So we're going to be aggregating a couple of measures of how people report the value they place on how their community invests in well-being. And I think of this in my own context of living in Philadelphia and the value I would place on how we spend in terms of community health promotion or where we're aligning our dollars and services and systems, and very much think that we have a lot to learn in this area, but I'm excited about that. I'll say too about this action area, it's been very well received as we've been sharing about this, and people really buy into this idea that yes, this is foundational to the work that we need to do to improve population health and well-being, but we also recognize that we need a lot of evidence here to get to the point of making health a shared value. And Alonzo will talk about our new research programs that we think will feed into this evidence base and are very excited about. Second action area focuses on fostering cross-sector collaboration to improve well-being. And if I can just make a nod to the development of the framework, you'll notice gerunds for each of these action areas, and that's just something I took away from working through this, is that gerunds are very popular at the foundation. So we're fostering, we're creating, we're INGing. We're focusing on drivers of the number and quality of partnerships, originally called enumeration of partnerships, but again, our message testing with that one didn't go so well, on the investment in cross-sector collaboration, and also on policies that support collaboration. I think particularly exciting in this action area is what we need to learn. We know, I think, little about partnerships, about what promotes successful collaboration, about what impedes successful collaboration. And so exciting effort underway at the foundation to really learn about partnerships across the country, and I'm looking forward to sharing a bit more with you about that project towards the end of my time. One of the measures herein, and that Alonzo alluded to, is of community policing. So we'll look at the percent of full-time sworn personnel who've reported playing a community-oriented policing role. We developed these 18 months ago, and I don't know that we would have known then how timely such a measure would be. And this measure, I think in particular, is one that's important to also communicate what the role of a national health funder is in this work, and not only in signaling the importance of community policing, but also in the opportunity we have to learn from this. We're doing work actually in Baltimore with researchers from GW looking at pairing community policing with mental health evaluation at a neighborhood level, and really are excited about what we can learn there and the scale and spread of such an approach. We're also looking at business support for workplace health promotion. This is falling within the driver of policies that support collaboration. And we'll be working with the Health Enhancement Research Organization using their best practices scorecard to create an indice of employer-sponsored health promoting activities. I think, though, this is one of the measures that will likely evolve with time, and as we learn more about what specific mechanisms employers can apply to promote health. We're doing an exciting RCT right now with BJ's Wholesale Club, and really expect to learn a lot from that about, again, the specific actions that employers can take or don't need to be taking to promote health. The next action area, the opportunity for all to live, learn, work, and play in healthy spaces. The drivers very much build on research we've supported and research we will continue to support of a built environment and physical conditions, of the social and economic environment, and of policy and governance. Again, a theme with policy here, because you noticed it as a driver in the last action area. Alonzo will speak to a particular research program where we're kind of revitalizing, it's maybe in there. The measure here, which he gave a nod to, is of residential segregation. I'm going to attempt to do the explanation justice, as you've done this many more time than I have. But we have an indice of dissimilarity in this. Did I say that right? Okay. And that will really look at the evenness with which different racial groups are represented in communities. So again, I mentioned I live in Philadelphia, and if the indice of dissimilarity in Philadelphia for Asians to whites was 40%, that would mean that 40% of Asians needed to relocate out of the city to have a more representative population. I think, again, here, though, there's an important narrative that we want to be part of, an important action that we want to catalyze. And it's not about displacement, about needing people to relocate, but I think it's about highlighting those systemic inequities that Alonzo alluded to in these places that are have such profound and astounding indices of dissimilarity about what those people have access to versus people in other communities or other areas. We've also included a measure of early childhood education that will be measured at the census tract level. And some of these measures are aggregated up to the national level, and then some of them, as you'll see, are we're able to get a little bit granular with. So this is an example of one of those. We'll be looking at the percent of 3- and 4-year-olds in census tracts that are enrolled in preschool. I think in years to come, we'll look at their enrollment in quality preschool, but again, a limitation with the data and very much a part of this being a version 1.0 measure is that we'll just look at preschool enrollment right now. And you may have caught wind of our letter to the field that came out last week or the week before, that kind of highlighted priorities for the foundation in 2016, and very prominent among those was early childhood education and our investment in promoting social and emotional learning early in life, recognizing that very much lays the foundation for success in adulthood. And we're not siloing this, we're not focusing our approach here just narrowly on education, but also looking on the supports we can provide to vulnerable children and families, the support we can lend to trauma-informed care, and the like. But I would definitely very much signal this as an area of focus for the foundation moving forward. The fourth action area, focusing on strengthening the integration of health services and systems, gets, as Alonzo mentioned, to the balance of health and healthcare and social services. It's been exciting for me to have been at the foundation during this shift of kind of aligning the two separate sides of the shop. Very much see it as necessary work. As ahead of my time at the foundation, I was part of a network of coordinated care for the uninsured and underinsured in South Carolina. So a different experience coming from that to the foundation, but one that's really provided me with the perspective of why this work and this action area in particular is really important. We've included drivers of access, so to include access to quality care, access to mental health care, and also access to dental care, of consumer experience and quality, and also of balance and integration. And within that driver of balance and integration, we've included a measure that will be of the number of states with full practice laws for nurse practitioners. Pretty timely that we get to mention this today, given the Institute of Medicine report evaluating our work on the Campaign for Action came out on Friday. And it was really exciting to read and to see how our work and the work across all 50 states and the campaign coalitions has really promoted nurses in the role that they play in healthcare delivery. We've also included a measure of hospital partnerships, which is in collaboration with the American Hospital Association, who's been very much a strong partner in our culture of health work. We're using their survey of hospital executives, which I think it's an 84 response rate, so it's a remarkable response rate that we're very much excited to add our question to about the number of hospitals that partner with at least one or more community organization. And if I didn't mention this, you'll see baseline data on the cultureofhealth.org website. So just want to confirm that that's a baseline value and will be updated annually. So we're very much excited to see kind of where these numbers lend themselves. And I'd be remiss if I didn't also share that, we're learning a lot about hospital partnerships and some of these other measures through our Culture of Health prize-winning communities. So if you're interested in kind of how this work is taking shape, I would point you to those. And I'd definitely point you to the example from Spartanburg, South Carolina, because that's where I did my work ahead of joining the foundation. And I think that they are the bee's knees. So that example right there. Then, am I dating myself by saying the bee's knees? Okay. So we have 4 action areas, which we think we're all going to feed into this outcome area at the center of the model. So we want all of these actions to catalyze improved population health, well-being, and equity. And I'll build on Alonzo's point about well-being and the connotation this has, because I also think, in addition to really resonating with a lot of different audiences, it also signals thriving and flourishing, whereas we're not yet at a point of associating health with that. We've included drivers therein of enhanced individual and community well-being, of managing chronic disease and reducing toxic stress, and also reducing healthcare costs. One of the measures is of potentially preventable hospital utilization rates, and so we'll use SHADEC HICCUP data, which is the Healthcare Utilization Project data, to really track this number and hopefully to see change in the years to come. We'll also look at the caregiving burden, and this is another measure that we're going to be pulling data from the RWJF Culture of Health survey. So exciting that we're able to field this and get data, and hopefully, I guess another area that we'd like to see change here is more people measuring these things, because if we're measuring what matters and what matters changes, we'd look for this to send a signal of what's important to be mindful of. So that is a lot of information about the framework and the different action areas. But I wanted to also take the opportunity to talk about another project that I'm part of at the foundation that's really exciting, and of which Baltimore is also part, and that's our Sentinel Community Project, which we've been calling the proof of concept for the framework, where we have these hypotheses, if you will say, about what actions are necessary to build a culture of health, and this we see as our opportunity to kind of test those out. So we are working with 30 communities across the country, defining communities broadly to include states, to include counties, to include cities such as Baltimore and a tribal nation, to explore how they're building a culture of health, maybe what partnerships they have in place, what the historical context is there that's allowed them to get to the point that they're at, but have been pretty intentional in creating this project to be strictly surveillance. So we are going to be collecting data and monitoring these communities, but not providing them with targeted technical assistance or funding. That's, I think, really key here, and that we want to learn, but we don't want to intervene so that we can learn very specific things. That's not to say, though, that communities that are part of this project are going to be prohibited from getting cultureofhealth.org. You probably will expect to see some reports about these communities in the late spring of 2016. And then thereafter, some reports that are really highlighting themes that emerge from communities, what we're learning from the rural areas and the innovations they have in place to address complex care issues, or perhaps what state-level work is really manifesting down to at the local level. I think you're up.
I'm going to flip back just a little bit, because the Sentinel community, I'm going to go back to something I said earlier. In these 30 communities, that as Margaret said, they range from rural areas, different kinds of rurals, upper Midwest, five county health department where they describe the county as having far more cows than people, to San Diego, to White Plains, New York, to an Indian nation in Oklahoma. We're trying to understand, again, what we call culture of health. Others might just call collective impact, collective action, and we're trying to understand the variety of those practices, not just the best practices, but the enduring practices, the ones where people overcome obstacles and are really able to improve their health and well-being. So you'll see that both in narrative and data on our website, and it's going to be a really important set of information as we understand how communities around the country are really trying to do these kind of collective impact strategies to improve health and well-being. The next slide here is really to talk about the parallel between the way we're thinking about these issues and the way others are. And this is a slide, the Institute of Medicine, National Academy of Medicine's recent report, Vital Signs, recommended for the nation a number of areas where we should have measures if we're really going to try to improve health and well-being. And what this slide is really showing is the real symmetry between the kinds of things that we have been measuring in the measures that Margaret just presented and the kinds of areas that IOM suggested that we begin to look at as a nation. And we will be following up with IOM on how we develop and improve our national set of measures, particularly to understand community engagement, measures that really matter for improving health equity. We funded actually this particular IOM report, and then we're going to work with them to develop maybe a next stage of how we can develop better measures nationally, built upon some of the work we've been doing with the Culture of Health Action Framework. This is a slide that I've actually borrowed from my colleague John Auerbach, who's Deputy Director at CDC for Policy, that shows the similarity between our culture of health measures and the National Prevention Strategy, which you know is sort of the prevention planning component of the Affordable Care Act. And again, a lot of similarity between what the National Prevention Strategy is recommending and the kinds of things that we are looking at in the culture of health measures. And we're also working with Karen DeSalvo, HSS, and with IOM actually, on trying to really be a catalyst for a new way of collecting data, looking at measures that matter, thinking about how exciting it would be, say, if BRFIS had a more robust local data collection base to it, like the California Health Interview Survey has in California. I'm from California, so I'm used to having that kind of a database. Well, a decentralization of federal data collection that allow us to understand at a better level community nuanced data. These are the kind of discussions that we're having around, again, measures that matter, and a lot of resonance with CDC. In fact, I worked through this framework with multiple visits to CDC over the last couple of years. I mentioned that this is a evidence-based social movement that we hope to catalyze with our funding and through our partnerships. And the partnerships are just as important as the funding. Some of our partners now include the National Y, the United Way, the AARP, partners who can get to what I call a retail level of community engagement that foundations don't reach, and that are well-versed in how to connect at a street level. But we also are resonating with other existing social movements for well-being, sustainability, the resilience thinking. I won't call it a movement, but resilience thinking very much pervades what we're doing at the foundation. And we have a number of, actually two grant-making programs and one that will be announced shortly where building the evidence base for what improves community resilience will be key. Certainly the livability movement and AARP's livability index. Go to their website, a really wonderful interactive thing that they have on livability is really there. And then well-being. When we talk about well-being in this country, it's kind of like a jolt, but if you go to our neighbors of the north, Canada has a national well-being index. I just came back from the UK with some colleagues there. Internationally, well-being as an index of progress for health agencies is well established, so we are clearly working with that as well. I'm getting toward the end. I want to talk about some changes that have taken place in our formal human capital program, our leadership training programs, that we tried to align all of our leadership training and scholars and fellows program around what it takes to have the leaders who can advance this culture of health, particularly this cross-collaborative, boundary-crossing leadership. So our new programs, multi-sector leaders for health, which is training broad leaders from health outside of healthcare at many different stages of their development to really provide that kind of cross-sectoral leadership. Our diversity and health policy research, which is a continuation to bring underrepresented populations into doctoral training in health policy research. Our new clinical scholars program, which is at University of North Carolina, Chapel Hill, belatedly brings together together in that program physicians, nurses, social workers, a range of people who have terminal clinical degrees so that they can learn how to be leaders in that multidisciplinary environment in which they will work. And then the program that you were able to win here in a very, very what?
The program at Hopkins is actually diversity and health policy.
Oh, that's right. Pardon me. Thank you, Margaret. That's why we did this presentation together. Diversity and health. Interdisciplinary, right. Interdisciplinary research leaders is Minnesota. That's right, University of Minnesota. Okay, that is really the successor to our Health and Society Scholars meeting. So those are the 4 programs that represent our change leadership agenda now. And again, sorry for the mixing up my boxes here, but the diversity and health policy research one is the one that you got. I guess I was a little confused there because some of you know you put in 4 very good applications for all the programs. So that's a little bit of the reason for the cognitive dissonance in the presentation. I want to end with a couple of the many different research-oriented programs that we have that are aligned to building the evidence base for the culture of health. And if you go to rwjef.org, funding alerts, you'll see information about this throughout the year. But the 3 programs, and Margaret talked a bit about them, that are really kind of the sentinel programs for developing new ways of building evidence for a culture of health are the ones here. Evidence for Action is based at University of California, San Francisco. Nancy Adler is the program director there. They are really trying to build this basic science for what it means to understand the action areas and all the drivers across all the action areas and drivers. And they are unique in our programming on research where they take letters of intent continuously, and they have been inundated. But we are encouraging people to apply to that program. We have been getting some very innovative funding out of that, and the demand has been great. Policies for Action, Margaret mentioned this one. This was the evolved from the health law program at Temple. I would call it associated with Temple now, one at Michigan, one at NYU, one at the Urban Institute, that are bringing complementary policy systems analytics to this issue of what is the science of health and all policies. And then Systems for Action is the evolution of the public health systems research work that Glenn Mays has done at Kentucky, really moving beyond just trying to improve internal system dynamics within public health departments, but really to try to understand how public health, hospitals, other systemic players interact together. They will also have research hubs like Policies for Actions, but those are now currently under consideration. So that's where we are. We really want to be very transparent about how these changes have influenced our funding at the foundation, cultureofhealth.org, as well as our original website, rwjf.org. We'll have lots of information about the changes that we've made, funding opportunities, lifting up what we're finding in a very kind of rapid cycle way from our funding and our program interventions. And I really encourage you to keep up with us on that. With that, I think I'll stop, and Margaret and I can take any questions that you have. Don't all jump up at once. I know.
Maybe I'll start here. Let's see. If I can turn that on. Thank you very much for that overview, both of you. One question I have is how, on the healthcare side, this fits in with sort of the trends going on in healthcare.
Yeah. Was there a second part?
Nope, that's good.
No, I think one of the reasons, probably the second group I reached out to in research for the framework was American Hospital Association, because I think we're trying to capture this window of many on the healthcare side talking about population health, often maybe meaning population medicine, but there's an opening there to try to capture the spirit of recognition, I think much catalyzed by the Affordable Care Act, that the community dynamics are critical to care delivery systems in a way. The Hospital Association is really kind of a catalyst to defining with them what does excellence in community engagement for hospitals mean? How does it differ between academic medical centers, rural hospitals? We may even be providing a prize in consortium with them around about hospitals being a catalyst for what I call community health assessment 2.0, which means hospitals, public health don't do siloed community health assessments. They do them together. They involve communities as at the table, and they develop collaborative and sustainable and prioritized plans to improve population health. So that's one way that it connects. It connects on the healthcare side with the work that we're doing on our team currently called Value, where we're really working with a broad set of health sector players just to improve the value of healthcare, particularly from the patient experience sector. We have measures in that action area 4 around improving the consumer experience in healthcare. We have measures around trying to track the interoperability or hopefully the increasing interoperability of health information systems on that action area 4. So there's just a number of different ways that we're connecting with the health care side of the equation as well through our grant making program and some of our partnership programs.
Great.
Hi there, Joanna Cohn from the Department of Health, Behavior and Society. Thanks for your presentation. You mentioned the UK and Canada, and my understanding is that the foundation is doing some global work to maximize our learnings to improve the culture of health here in the US. Can you talk about that?
Yes. We have one of my portfolios. Our global solutions for U.S. solutions is our new global health program. It's focused, just as the name implies, on learnings from across the globe of ways other countries have tackled problems we want to tackle so we can scale and spread them here. Often in a partnered research way, we'll pair an international partner with a U.S. partner to modify and scale and spread. And it ranges from partnership to a researcher in Brazil and a U.S. partner around how to increase community physical activity and things like ciclovia. So all different kinds of approaches. But I always say we're not developing mission offices, and we're not Ford or Gates in that regard. But it's a very niched kind of global program. We just hired a new global director who got her DRPH here. Yes. Okay. Yeah.
Good morning. My name is Keisha Pollack. I'm faculty in the Department of Health Policy and Management. I want to thank you and Margaret for your comments today. I'm curious what the thinking of REL is regarding measuring how you're going to build the social movement. I really applaud the foundation for talking about building a social movement and wondering collectively how you're going to measure that part of your work around culture of health.
Okay. Thank you. And I just read your excellent review and all your interviews of our equity work. We should like to talk later. Well, first of all, this is the one foundation. REL's kind of the catalyst. This is the one foundation thing. So this is not the REL measures. It's the foundation measures. It's an interesting evaluation framework, this Uber evaluation of what we're doing. But part of it, and I'll talk more about it later. We're putting this together now for. We'll be ready to release the sort of first evaluation of the overall effort probably in the first quarter of 2017. So it involves a lot of different components. And I'll just start with the outside. It has all the ones you would expect with our own grant making and all of that. But we're really trying to understand this movement building component. So the key part of the evaluation for understanding the movement building is our partnership strategy, which is a very intentional part of the strategy building. So we have a taxonomy of partners. I spoke to one part of that taxonomy already. Partners have a very different reach than we do at the street and retail level with community engagement. So how many of those partners are we able to engage? What difference is it going to make in terms of some of the drivers and measures we want to improve? For example, the Y partnership is engaging the Y to really use its niche in the lives of families families across the country to improve child and family emotional health and well-being. There'll be outcomes attached to that. With United Way, 211 systems are entirely underutilized as early indicators of need in communities. If local United Ways that run 211s can begin to utilize 211 in a different way as a sentinel indicator of need. When I was running county health departments, 211 get another early indicator like that. So that's one thing, understanding the range of partners and what they do. And not just partners we fund, but a lot of partners that we engage, other foundations, and how they are realigning their work. And then we're doing some interesting general kind of media analysis to understand how this is shifting and changing, both with mentions of culture of health, but also measuring other culture of health-like activities, collective impacts, strategies that seem to be scaling and spreading related to this kind of movement, a number of those different kinds of ways. But I think the key thing is, and I'll give one example of something that will be in the success measures already. I got a call from the state of Washington where they asked me if they could use the action framework as the framework for their accountable care community work. That's a scale and spread movement building relation. So we're looking, and there are a number of those kinds of things. So, okay, and then one more thing. Then we have a national survey by NORC at University of Chicago that's kind of measuring sort of the national sentiment about health and well-being. We got a baseline that'll be out late winter, I think. Now we have a base evolving. Okay.
Hi, good morning. I'm Ron Getzel. I'm on the Faculty of Health Behavior and Society, and I applaud RWJF for its pivot into this area of culture of health and all the expansion of your efforts, including involving many more stakeholders in these efforts, and also all the measures. So on the topic of measures, there are now 31 measures, and I'm a metrics guy, so I love measures, but there's also the danger of overwhelming people with measures, and certainly with healthy people, hundreds of those measures, and it was always unclear as to which were more central and which were less. So I'm curious to know whether your report back to the stakeholders will be focused on the measures that are relevant to them, that are tailored to that audience, or whether you're going to come up with general care or public health in general, things like triple aim, access, quality, and cost issues, and how your initiative will influence those kinds of things.
Great. I wish we only had 31. We have 41. I only really wanted about 30, and you're exactly right. Part of the work in this year with those 3 research programs, and actually part of an open kind of dialogue we're going to be starting on cultureofhealth.org, is to generate parsimony in the number of measures. And some of the research, we've got 2 housing measures in there, residential segregation and housing affordability. Well, maybe one is more, my bet is that residential segregation may be the really powerful one that we can align around. So we're really looking for parsimony in that. In the national measures, but they will still tie to national indices. The whole kind of purpose of the Sentinel community studies is just what you said. What measures matter to people? What are they using? Which of ours are useful to them? Which ones are not? And so we're trying to both understand from these 30 different communities, all of whom are using some kind of measures, what measures are meaningful to them. That will help us understand what we might do in the national measures. But we're trying to be very clear on it's the framework and the drivers we're trying to have the conversation around. There are many more nuanced local measures that will have much more meaning to them. And so I think that gets to the spirit of what you're saying.
Morning.
Morning.
Karen Davis in Health Policy and Management. This is a great framework and obviously a very ambitious agenda, so compliment you on that. Which leads to my question is what criteria you use in setting priorities among all the things that you could do, and some sense of budgetary allocation across those areas.
Okay. And I would refer you to Risa's letter to the field that just was put on the website, because when we've developed this framework, it is both our foundation's whole strategic framework, but it's also a framework that we hope will catalyze a lot of other national activity. It doesn't mean that we can't operate in every one of those areas that we've talked about in the action areas. So we've come up with a couple of thematic areas that we think are the best fit between some of the urgent areas that we need to move in and what the foundation can do. Margaret mentioned one, early childhood. Communities, the work we've been doing with the Federal Reserve, both in Minnesota and in San Francisco, this convergence of community development, community developers, banking, how, the code word for it is how can you provide high quality, affordable housing in urban areas without gentrifying and putting in the mix the kind of services and grocery stores that people need. That's emerging as a particularly important leverage area for us. Certainly, the evolution of our work in value and coverage will continue to be there thematically. So we're picking a few areas within the action framework. All of our work will tie to it. But for example, we have a measure on essentially climate resilience, climate change. Not an area that we will be largely involved in programmatically in the short run, but one of the measures that we're lifting up as very important for the nation to be concerned about and other partners who we have, like the National Resource Defense Fund, who work on. So I would refer you to the RISA's letter to the field that lays out these 4 areas: early childhood, community development, value, quality, and healthcare, and one other that I can't remember right now, as the themes in which we're organizing our work. I think that letter also talks about the way some of the internal teams are prioritizing this. But again, this is not an initiative, this is the whole foundation. So over the course of the 20 years, at current payout of around $550 or $600 million a year, this is that's the scale of the funding for this. All of our funding is aligned around this.
Hello, good morning. Sorry, I'm too short for this. My name is Ziqing. Thank you so much for both of your presentations. I'm a first-year Master of Public Policy student. I'm interested in the aging population. So I know that your organization has awarded grants to the Greenhouse Project for more than 10 years.
Yes.
And the aging is a global issue now. But because I've started to look at summer internships recently, and I look at your website. So your focus areas, like senior services or the aging is not among your focus areas. So I'm wondering, are you allocating more resources in the future maybe when aging is more like a severe problem in the US, or is still not your focus?
I think aging's already an important problem in the U.S. I think the way we're trying, we are funding a number of things that relate to that. And I think in the action framework, think about these measures or the way they kind of crosswalk to the concerns of improving health and well-being for the aging. Our measure on complete streets policies, which essentially is a measure that you have coordinated transportation, urban design, community design principles that make it easy to live and walk about safely and actually to age in place. We consider that one of the measures that opens up into what you need to improve health and well-being for an aging population. In fact, we share that indicator with AARP's livability index. Caregiver burden, another one of our measures, is another window into some of the dynamics of an aging population. So just because we don't call out something like aging, I think about the implications of the issues that are signaled by the measures as the pathway to that. And we will continue to, and the reason we talk about the framework being relevant across the lifespan is, though we have this early childhood particular focus, we're continue to be interested in health across the lifespan.
Thank you.
Ian Ramon from the Bill and Melinda Gates Institute here at Hopkins. I must really congratulate you for what I think is a brilliant conceptual framework, Culture for All. I do most of my work globally, But when we talk about culture for health, at least in my experience globally, it's more of a shift in terms of the paradigm of thinking of people as producers of their own health. So it's a question of who produces health. And normally in developing countries, they would look at that in terms of ratio of population to doctors, to midwives, to clinics. But when in the agriculture sector, when you say who produces food, it's not the Ministry of Agriculture, it's not the hospitals or whatever, it's the farmers. So in that context, we say who produces health, it's not necessarily the hospitals. You know, it's the people. You could shift it around and say it's the people. People who don't smoke, they produce health. People who don't openly defecate, they produce health. People, you know, children who have access to good nutrition, they produce health. So I thought that your concept of social movement in the way you conceptualize is really brilliant. However, I was looking for those measures which look at the demand side, where people are actually becoming producers of their own health, and yet I have not yet seen that. But maybe it's buried somewhere there.
No, that's a wonderful articulation of what we aspire to. Which is health is a multi-sectoral production function, as you outlined, and that's and the decisions that we're able to make every day around healthy choices is a large determinant of health. So we resonate with that. Some of the measures that are those are the toughest measures to get. That I think Margaret mentioned in this Action Area 1, changing the national health narrative about what generates health. From I just have to have an annual physical, which is, the healthcare side is an important part, but health is generated many different ways. So we're the measures of how that national narrative is changing is in this University of Chicago NRRC national survey. That's going to be an indicator of how people are people thinking about making decisions, thinking about health in the way that you're doing. You talked about. We also, in some of our work, in our childhood work is our big commitment to eliminating childhood obesity, a big focus on the healthy food production side with a set of big bets to renorm consumption behaviors, say for families with kids from 0 to 5, that there should be no sugar-sweetened beverages that a child from 0 to 5 have. That's sort of an advanced industrial food production problem, which is sometimes the caloric reverse of some developing nations, but that's actually converging. So we have a number of major initiatives that are involved with alignments with sectors whose role could be enhanced around their contribution to the health equation.
Great. Well, maybe I'll take the liberty of one last question, but it's for Margaret.
Yes.
Is that okay? Which is, as you work at the foundation and you're in school here, what do you think about what students should be thinking about studying and working on as you see firsthand the direction of the foundation? And you can, go on up, because we're recording this, so all of your colleagues will be able to hear.
No pressure. I really think of my public health training and the kind of time that I want to spend after the foundation, and the sectors that I would imagine myself entering that really don't view their role in a health context. I think that's been an important theme that's emerged being part of this work and learning about all that we want to bring into this group and all that I see myself being part of as a public health student. I was talking with a colleague recently and thinking, I know a public health degree is the right for me, but I very much wish that I was going to be shoved into another sector upon graduation, but I see myself doing that.
It's a great point. It kind of opens up the idea that maybe we should be marketing the MPH to other sectors, as a way of thinking about a problem, maybe more so than the subject matter expertise in health.
Right.
Well, please join me in thanking Dr. Plough and Margaret for this. And we need you to go out and, tweet with us, Pub Health Chat at noon, and get all your friends, colleagues, family members, everyone in your address book to join us. Thank you.